Okay, I'm Singo Kasahara, Okayama, Japan. I'm a cardiac surgeon. I just talking about that recently, the very rare about that tetralogy of Fallot after the repair patient. Usually to the tetralogy of Fallot is dying very rare because of that the surgeon is good hand and also pre-diagnosis is much better. And then, but this one is very simple and also very much occasion to that every cardiology, every cardiac surgeons do that this operation. But I'm not sure that the patient why that died. I'm not that details. I'm not sure. But I just talk about that explanation about the anatomies. We usually thinking about that anatomies and before thinking about that heart specimens have a look to that outside aspect. Which side of the left side? Which side of the right side? Put on the normal side. Surgeons usually to that this one, but the heart specimen have looked to that this one is much easier. Then at first and identify the right side atrium, left side atrium. That shaping is very important. What the difference of that left side atrium? What side of that? What shape of that right side atrium? This one is operated and right side atrium. Right side atrium is that appendage triangular aspect comparing to that left atrium like here, finger like, and then a little bit small. Left side is the left atrium, right side the right atrium, situs solitus. That's the beginning of that explanation about that anatomies. Then have a look to that aspect of the relationship of the great vessels. This one is a big tubing system from that heart, and another aspect is some operation in somewhere here, and then big tubing is somewhere here. This one is some branches there. First branches, brachiocephalic trunks. Next branches in the left carotid arteries. Third branches, left subclavian arteries. Next three vessels there. Usually first branch is brachiocephalic trunk. Should be left aortic arches. And then probably big one is that identified aorta. Big aorta, something happened to that the pulmonary arteries here. Aorta is that right side, then behind comparing to that the pulmonary arteries. Pulmonary arteries, left side, then anterior. That's a normal relation of the great arteries. Have looked to the C, situs solitus, and should be to the great vessels relationship is okay. Then have look to the inside. Otherwise, to that the coronary arteries maturation is very important. And right coronary arteries and the big branches are closing to right outflow tract or not, and then left descending aorta here and the posterior to that circumflex or not. Have look to that. It is important. And then open the right atrium here. And this is a little bit smallish one. Inside the right atriums, very important anatomies here. Usually to that should be to here, SBC, should be to here somewhere, IBC is here, and foramen ovale or ASD already closing. And then another things I can see coronary sinus is here. Coronary sinus, and then have a look down to that right ventricle, septal tricuspid leaflet, anterior tricuspid leaflet, and then posterior tricuspid leaflet somewhere. Coronary sinus here. It's okay. Coronary sinus is here. Can you more big one? Can you more big? Zoom in. This is coronary sinus. Septal tricuspidal leaflet here. This one, triangle of Koch. And the top of that triangle, this one is a AB node. This one is a very important area for surgeons because of that some conduction tissues who are very important to closing the BSDs. And sometimes the tetralogy of Fallot, big ASDs there. In such a situation, smallish the tricuspid valves, smallish right ventricles as well. But combined to the tetralogy of Fallot, big ASD patient, small tricuspid annulus, small right ventricles, concerned about that biventricular repair. And then have a look open to that right ventricles here. And the right side aspect of that tricuspid leaflet, very interesting. Septal leaflet, just attached to that interventricular septum. Not so big papillary muscle like mitral valve. Then have a look to the inside the right ventricles. Thick trabeculations. Many thick trabeculations is there. And this one is already operated. This one is a BSDs. This one is continuous stitches. Usually, this one is a thick Daclon patches there. But we cannot see that overriding to the aorta, but we can easy to see open the right ventricle to aorta is we can see that easy. Usually to that BSD patient, normal BSD patient, we cannot see that aortic valves, but tetralogy of Fallot, we usually too can see that aortic valve. That's the reason why aorta shifted to that anterior side. Overriding it means. And then little bit difficult to see that this muscle, trabecular septum marginalis. And then this one is near the infundibulum septums, trabecular septum anterior extension. And then this one is a posterior limb as well. Between the tricuspid valve and the aortic valve, ventricular infundibular fold. Usually to that close the BSD, very important to avoiding tricuspid valve regurgitation. And some cases through the tricuspid valve, the stitches through the tricuspid valve to BSDs. But if we identify the ventricular infundibular fold, that we can use to the muscle after that tricuspid valve regurgitation very minimal. So tetralogy of Fallot, it is very important to identify ventricular infundibular fold muscle using to for BSD closure. Then have a look up to that pulmonary arteries. This one is an infundibular septum. Probably some cutted muscle is here. Infundibular septum, anterior deviation. Behind to the aorta shifted to the anterior. That's the reason why infundibular septum anterior deviation cause of the subpulmonary stenosis. And this one is some open transannular patch, put on this one, and then operated. But still very thick right ventricle, still high right ventricle pressure, cause of that arrhythmia or something, I'm not sure this patient. And then usually we cannot see that left ventricle aspect. Left ventricle is here. Usually to that tetralogy of Fallot, left ventricle is normal, but a little bit smallish. And then much different to that inside aspect of the left ventricle comparing to the right ventricle. Very fine trabeculation, but some thick of that muscle is there. And also mitral valve is very same. Then probably this one is a little bit smallish left ventricle, a little bit cause of that heart failure after the repair. And then come back to that aspect of that outside. Very important to that left side and right side, which is which. In that beginning of the explanation is much better good understanding for anatomies. Thank you very much.